Welcome back. As Alzheimer's therapies continue to make great progress, questions remain about how we can ensure equitable access to the right treatments for the right patients at the right time. What do we know and not know about the causes of the disease in and the impact of new treatments on minoritized and especially Black populations? And how do we achieve success with such low rates of diversity in clinical trials? Kicking off today's discussion on the issue is Stephanie Monroe, Us Against Alzheimer's Vice President and Senior Advisor of Health Equity.
Us Against Alzheimer's, since its founding, has prioritized the importance of eliminating disparities and promoting brain health equity. We were, in fact, the first national organization to establish networks specifically focusing on minoritized populations with a high prevalence of Alzheimer's disease. We examined African Americans and Latinos. America will soon be a 50-50 majority-minority population. Yet over 85% of clinical trials in the U.S. are virtually all white. In fact, the U.S. Food and Drug Administration approved a record 59 new therapies in 2018, but among the 53 drugs with U.S. clinical trials, only 12 had enough data to provide some knowledge of the drug's effects across races. This is according to the FDA's own drug trial snapshots. Today's panel will explore the key question of how we achieve success with such low rates of racial and ancestral diversity in clinical trials. Our panel today, made up of some of our most leading experts in this area. Dr. Consuelo Wilkins, who's an MD, is Senior Vice President and Associate Dean for Health Equity and Inclusive Excellence at Vanderbilt University Medical Center. She's a nationally recognized thought leader in health equity and in addressing the elimination of systematic inequities that impact the health and well-being of minoritized racial and ethnic groups. Lisa Barnes, PhD, is the Olive and Solomon Jesmer Professor of Gerontology and Geriatric Medicine and a cognitive neuropsychologist within Rush Alzheimer's Disease Center at Rush Medical University's Medical Center, where she's also the Associate Director. And Dr. Walter Korschutz serves as Director of the National Institute of Neurological Disorders and Stroke, which oversees much of the Alzheimer's-related dementia research at the NIH. He joined NINDS in 2007 as Director and has held leadership roles in a number of NIH and NINDS programs, including leading the NIH's Brain Institute. Okay, so let's get into it. Thank you all for gathering to have this important conversation about equity and what we know. So Consuelo, let's start with you. You conducted the IDEA study, which included over 17,000 individuals with mild cognitive or dementia and amyloid PET. You analyzed between, my understanding is between April 2020 and January 22, what is likely the largest multi-state study to date examining the differences of amyloid PET. And we know that this is very important for a lot of the new therapies and drugs that are going to market. So tell us, what did you find?
Well, Stephanie, thanks so much for having me. I'll first start by saying I cannot take credit for conducting the IDEA study. So IDEA is a great team of folks across the country. As you mentioned, more than 17,000 people involved in the IDEA study, which looked at the utility of amyloid PET in this large group of individuals with either MCI or dementia. The most important and striking thing to me about it is you've already pointed out some of the inequities and inclusivity in the studies. Less than 10% of that study population were people from marginalized and minoritized racial and ethnic groups. And so, of course, we know African American, Black, Hispanic, Latino, Latina populations are suffering disproportionately from Alzheimer's and dementia. So to have yet another study looking at this critical biomarker have these populations being underrepresented was really concerning. So fortunately, the ideas team approached Dr. Peggy Dilworth Anderson and I about after they recognized really this lack of inclusivity in the study. And so one of the first things that we said was, okay, well, what did you find in the original idea study? And turns out, like so many other studies that are published, they didn't actually disaggregate the data or look at the outcomes by race and ethnicity. And so we did the secondary data analysis, which was published about a year ago. And in that analysis, which, as you mentioned, it still has largest groups of Black, Hispanic, and Asian populations who've had amyloid imaging, we found that individuals from all of those racial ethnic backgrounds were less likely to be amyloid positive, whether or not they had MCI or dementia. So it certainly calls to question, whether or not, as we have more, this increasing number of monoclonal antibodies focused on amyloid, anti-amyloid therapy, will it work in these populations who are less likely to be amyloid positive?
So what does that mean? Does it mean that amyloid is not really causing Alzheimer's disease in these populations? What does it suggest?
I think we don't know the answer to that. It could suggest that maybe there are other pathologies happening. Perhaps there's more vascular disease that's co-occurring in these populations. But it should make us ask the question if people, these populations, specifically Black and Hispanic people, are more likely to have dementia and MCI, what is the underlying cause? And I think the most important thing we should say is that it does not necessarily reflect some underlying predisposition to the condition based on race or ethnicity. We have to think about social conditions, social factors, which of course can contribute to increased vascular disease. We should be considering whether or not we need to rethink the cutoffs for these populations. Mm-hmm. If there in fact might be more mixed pathology in these populations, again, should be looking at those people who might be indeterminate at the cutoffs. But I think it really we have these drugs that we've been all anticipating, new therapies for Alzheimer's, that are unlikely to work in these populations because they have they're not reaching that threshold of amyloid positivity.
And I see also that one of the challenges is that we don't, many of the trials that are looking at these new therapies are setting amyloid load as, like you said, a cutoff. And so we've got this catch-22. We need more minorities in the trials, but the trials themselves are being designed in such a way that the populations are being excluded because they don't have enough amyloid. So Dr. Barnes, let me just flip over to you for a second. I don't understand what's that all about? I mean, how can we achieve equity if we're excluding populations who need these medications, but for whom these theories may not be appropriate for them? What do we do? Do we need to just change the type of clinical trials? Do we need to change the criteria by which people get in and get out to achieve equity? What do we need to do there?
Thank you, Stephanie. I also want to thank you for inviting me to the conversation. And I want to also say that I'm super excited that this conversation is happening at the beginning of the summit, yes, instead of at the end. That's really refreshing. So, you raise a good point about the trials. I think we need a major overhaul in many areas of how we're doing trials. But if we're focusing specifically on recruitment, we're not going to achieve equity if we continue this practice of exclusion. And so we need to be thinking about what we have to do. I won't speak about whether or not we need to change the cutoffs for amyloid. I think we don't have enough data to really know. In my own studies, I don't see differences between African Americans and whites as far as amyloid in the brain at death, at postmortem. So I think there's a lot more we need to understand about what's shaping amyloid. But I will say, for recruitment purposes, we know that many studies, especially clinic studies, that they only are recruiting from their clinics, right? And we know that minoritized populations often have less of a a lower or a more fractured relationship with healthcare. And so they may not be presenting to these clinics. And so we need to be able to go to communities and do a lot more outreach to get people interested in trials. I think that's going to be one major overhaul, and maybe Ideas 2 is doing that, Consuelo. I'm sure with you on the team, that's what's happening. But traditionally, we have just put a flyer up in the clinic and advertised for a clinical trial, and that's clearly not working. I think that the other thing we need to do is educate the community more about this disease so that people can make an informed choice about whether or not they want to participate. Because it's really clear that people still think that Alzheimer's is a normal part of aging. There's nothing that can be done, so that they don't think research is a viable option. So we need to increase education. I think the third thing we should do is diversify the teams, as Ideas did very smartly. A lot of our teams are still, very homogeneous, and people want to see themselves when they come to a study. They don't want to just see people who don't look like them. So we need people to be, diversifying the teams, people who can make decisions, and really change the course of the clinical trials. And I think the last thing I would say is we need to modify the inclusion-exclusion criteria, because it's clear that people are getting kicked out of trials because of the comorbidities that they might have. And we know that minoritized individuals are more likely to have, vascular disease and other comorbidities. So we need to be able to figure out how we're going to target other things other than amyloid so that we can let more people into the trials.
That's really makes a lot of sense that we need to do that. And I know we've spent so much time. I was on a group with NIH coming up with a big fat guide on recruitment science, because there are many who know how to do this. They've done it well, they've done it right, but getting certain, large academic centers to spend the time, the resources to actually go into the community, not themselves, but maybe using promotoras or going in and getting someone in the community who's already trusted and embedded. Exactly. And let that person be your outreach coordinator. We know how to do this. So what's it going to take when at the back end, I guess there's no real accountability, when you can have a, drug potentially go to market with 3% minority engagement, and that's okay. I mean, it doesn't make sense. It wouldn't give me, if I was just if I'm a lay person out there and my dad's been living with Alzheimer's for over 10 years, gosh, if I knew of those low rates of participation, that would be very, very concerning. And doesn't that actually instill even more fear and less trust? So these are really big and complex issues about why we're not doing what we know and not holding people accountable for those results in particular. Talk to me a little bit, because I know that, if you're saying that, and I think Consuelo and you both have suggested that, the etiology of Alzheimer's disease in Blacks and Latinos might be different. So we're studying people with, for the idea of getting, getting more drugs to market and treatments and things like that. But basic science seems to be something you're suggesting that we need to do. And I know brain donation has been something that both you and Dr. Korowitz has been being able to talk about, want to promote. So can you talk to me a little bit about brain donation and why that's important? And are we getting what we need?
Yes. Yes, thank you for that question. Brain donation is really important, especially for ADRD, because we know from our studies in mostly white older adults that most of the causes of dementia are due to mixed pathologies. So, we tend to focus on amyloid and tau, but there are a host of other pathologies in the brain that can lead to loss of cognition and lead to ADRD. And people can have a multitude of different frequencies of these pathologies. So there's not one size fits all. We would never know that if we didn't have people donating their brains. Unfortunately, there is a huge disparity in brain donation where minoritized individuals are much less likely to donate. And, there's all kinds of theories about why that is. But the most important thing is that we need to, as academics and, and healthcare practitioners, get out there and spread the word about the importance, because if we can't see the brain after death, we will not know what these different pathologies are that are contributing to cognitive impairment in these populations. We've already talked about vascular disease. There are going to be infarcts and small and large vessel disease pathologies that can only be seen right now under the microscope after death. We're changing, we're getting more sophisticated at looking at some pathologies with PET imaging or, cerebral spinal fluid, but there's some that we still can't see. We only can see them under the microscope. So that's why it's so important to have brain donation.
That makes a lot of sense. One of the things that I experienced when I was out doing community work and using the play Forget Me Not that was sponsored by Us Against Alzheimer's, and we reached over 30,000 people. And we found that, again, the way you reach communities is to do what a community wants to do, what they will respond to, and then deliver them messages that they can access, they understand, with trusted messengers in the communities themselves. But one of the things that we did, we surveyed people, and we found that when we asked the question of, has anyone ever talked to you about participating in clinical research, or even frankly about your brain health, about 80% of the people said no. This was consistently across the United States, okay? And these were African Americans right in that catchment age that we were trying to get. 80% said no, no one had ever talked to them or asked about it. I'm wondering if that's also part of the problem with why we're not getting enrollment, because people aren't being asked. And I wonder if that's also why we're seeing lack of brain donation. My dad's, like I said, has had Alzheimer's for 10 years. No one's ever asked him about what he would like to happen to his brain or our family afterwards. So Dr. Koroshetz, is there something that NINDS has been leading or talking about in terms of how we increase brain donation, not just for Alzheimer's, but for other neurological disorders?
Yeah, Stephanie. Yeah, good point. I think, the issue with the best treatment for the person depends really on what's going on inside the brain. Now, of course, in the living individual, you have to rely on surrogate markers like PET scans or blood tests. We can talk about those, but they're valuable when they correlate with what's in the brain. So that's kind of the first step. What we've done, because it's for all the diseases that we deal with, we're in the same boat. We work with a woman named Tish Hevel, who started what's called the Brain Donor Project. And Tish is just very good at communicating the value and making it easy for people to think about this. But it is incredibly valuable. And I would say that the tools to look at the brain now are just astronomically better than they were 5 years ago due to the Brain Initiative. So I would say in our field now, trying to understand what's going on in dementia, the key is to really dig deep and see, what cells are affected, what parts of the brain, what's affecting them. And I think, as Lisa said, the thing to know is that the older you get, the less likely you have just pure Alzheimer's disease. In the US, it's always been called Alzheimer's disease, but that's not true. It's generally a mix of different things. And the three most common ones are vascular disease, which is more common in African Americans, then the amyloid pathology. There's a new one called TDP43, which is another protein that aggregates and causes severe memory loss when we're elderly. And that's common actually in ALS and what frontotemporal dementia. And then the last one is Lewy body disease, which is another type of aggregate that occurs in the brain in people with Parkinson's and some people who develop that in their cognitive areas even before they have the symptoms of Parkinson's. So those are the kind of things that are mixed in people. And so rationally, you would think that any therapy has to be focused on, what is in an individual's brain at the time. And the biomarkers are getting pretty good at detecting signs of amyloid and actually Lewy body disease. And MRI is quite good at vascular disease. So I can see in the future how we can put together, a mixed pattern and try and understand, what therapy is right for the right person. So right now, I would say one thing is that it's very important not to conflate the FDA approval of a drug with who should actually take the drug.
Hmm.
So the FDA is regulated by law, and a company just has to check the dots and show X, and they have to get approved. And there's no way you cannot approve it unless Congress changes the law. So FDA approval is only the first step. Once it's approved, then the big question is, who does it work for, when? And that, I think, is what the science is going to have to figure out. So we're really at the early stages, but that's where we have to push. So for instance, our institute at our last council agreed to do an initiative to test anti-amyloid therapy in people who have vascular disease and amyloid, and try and figure out, does it help those people or not? And we need to do something similar in people who have Lewy body disease. So this is just the beginning.
Yeah.
And you're right, there's a lot of open-ended questions we don't know the answers to, but that's why the NIH science is really, really called to answer those questions now.
So you've opened a little bit of a can of worms here.
Yeah.
Which
Stephanie, I'm wondering if I could just respond there. And first, Walter, thanks for sharing that. Really great to hear that approval of plans to test these therapies in people with mixed disease. But I guess I would push back a little bit on the FDA and kind of the lack of accountability there. I mean, I think that as long as we continue to accept that drugs are being approved, drugs are being studied in samples that don't reflect the people who have the disease, it is problematic. So we keep talking about Black people being twice as likely, Hispanic, Latinx folks being 1.5 times as likely to have dementia. So to have trials that have populations that have less than 5% of their study sample being from these populations is just not good science. And I think at some point we have to push the FDA and the committees to take a more critical review and have higher expectations. I mean, we continue to see the FDA say diversity is important, there's more guidelines, but there's no accountability. And similar, I think, NIH has had more than 25 years of, expectations that we have diversity of women and marginalized racial and ethnic groups in trials, but we continue to fund and support studies that don't meet their accrual goals, and there are no consequences. And so I do think that we have to up the stakes there.
We're continuously pushing.
Yeah.
This is not taken lightly at NIH, I can tell you that much. But I think the FDA, just to remember, you would need to change the law that regulates the FDA. Now, I'm not saying that's not a bad thing to do. I'm just saying that's what.
Well,
those can change. We see it like every day, right? Well, not we see it. We see it happen.
The other one is kids. Most kids are treated with medicines that have never been tested in kids. Yeah, there's a lot, and it's really not good. What's that? The way our system is put together is not in any way equitable. Yeah.
It sounds like a systemic issue that needs to be changed the highest levels.
And it's a serious issue because, we know that doctors can prescribe medicines for off-label use. So the label is really important. But if you're a doctor, and we've got two right here in the room, how do you translate this science, which might not be the best science, and do you have the time to figure out what then is really good for my patient? We've talked about precision medicine, right? But we can't be precise if we don't know specifically what our patients need. So what do we do there? What do doctors do? Especially with these new medications. I don't know what you all do, but tell me what you do.
I mean, I'll certainly, agree with Walter. You should be treating what's in the brain if you know what that is. And so, with these, anti-amyloid therapies, the expectation is that, some evidence of amyloid is supposed to be confirmed before you actually use the drug. So if we're following those guidelines, it doesn't matter what your race, ethnicity, ancestry is, if you meet that criteria, then you should, be eligible for the drug, and presumably it should work again regardless of your race or ethnicity. But let's face the facts. When we're seeing patients, when families show up at our doors, in our clinics, in our health systems, and they've been waiting for something that is going to give them hope for them or their family members, it is really hard to convince them that they shouldn't take the newest available drug. And so, that's some of these conversations that people are having, and, being firm to say, you're really not eligible for this drug based on, the guidance and, how it was studied, is a difficult conversation to have. And it's certainly challenging when you're talking about most of if you're seeing a patient population that's mostly Black and or Hispanic, that, we're saying no more often than we're saying yes.
And the other problem is this is not an entirely safe therapy, unfortunately. There have been deaths due to this therapy. And that's because the therapy, which is trying to get the amyloid out of the brain area, cells of the brain, causes inflammation in the walls of the blood vessels and causes swelling of the brain and bleeding into the brain. And that affects your use of other medications, for instance, for stroke or heart attack. So this is a very complicated dialogue that you have to have with patients. And as Consuelo said, it's a really tough decision. And you have to respect the patient's wishes, like she said, but they have to know what the risks are going in. And the more ambiguity you have, the harder it is to have that conversation. And that's why we need more data. So if you look at the lecanemab trial for anti-amyloid, they had like 800 to 900 Caucasians. In each group, they had 20 African Americans. And you can't make any assessment at all. And the other issue is that there's this isoform called ApoE4. And if you're a homozygote for ApoE4, the drug looks like it didn't help you, and it puts you at very high risk of bleeding. And we know that ApoE4 is in African Americans does not have the same effects as it doesn't have Caucasians in terms of Alzheimer's. But we don't know if that's true about the anti-amyloid risk either. So there are real issues. Now, if you have, and to get the drug, you have to get genotype for ApoE4. So not only do you know if you have the ApoE4, but then everybody in your family knows. And so this has huge impact. And there's all this ambiguity about what it means in the African American community. So I think a real kind of cogent example of how you can really get into a bad situation due to lack of information.
Just to add to that, Walter, we also know that African Americans have a higher frequency of the E4 allele. That's been shown in a number of studies.
And what about the ABCA7 gene, which I understand is a better indicator in African Americans as a biomarker? Why aren't we using that in our clinical trials once we do confirm the ApoE4? Would that be helpful?
It would be good to know what its effect is on the effect of the drugs or on the effect of the risk of bleeding. Because you're right, that isoform is much more common in African Americans than it is in Caucasians. And its influence, Lisa, correct me if I'm wrong, or Consuelo, its effect on Alzheimer risk is at least as high as ApoE4 is for African Americans. And it's been we don't know much about it in terms of what it does or how it affects things like bleeding or amyloid around the blood vessels. Those kind of things are really important to understand now.
Well, I'm going to summarize sort of where we are right now, because we're starting to see some questions come in from the audience that we want to be respectful and respond to. But it seems like we're talking about really 4 different things here. Knowing, like, what do we know and we don't know about Alzheimer's disease in Black and other minoritized populations, especially concerning the role of ApoE4, ABCA7, and other biomarkers. Are researchers asking the right questions? Secondly, are we having the kind of open discussion and response to these new learnings that are coming in? Or are the research hypotheses too far out the gate? Thirdly, are we implementing what we know? There's a need, but is there an appetite to explore additional hypotheses that may create more of a equitable response to potential treatments and to addressing Alzheimer's disease and related dementias? And then fourth, are we setting the kind of goals that we need and holding researchers, industry, and regulators accountable? What are the weakest links? And so I'm going to come back to that last question after we quickly turn to some of our audience questions, which are important. So here we go. We've got one individual who is asking, she says, I'm a Latina with a family history of Alzheimer's, and a PET scan has shown abnormal amyloids. She wants to help improve science by volunteering for studies, but the problem is that all of the studies need MRIs, and that she has a bilateral cochlear implant, so she can't have an MRI. It's frustrating, she says, so she stopped looking. And what do we say to someone like that who wants to get involved? And this is a very specific incidence, but other people who want to get involved, but they're not able to. Is MRI the only way that we can let someone in who can't get in because of implant? Any response to that?
Well, certainly for the anti-amyloid therapy,
Looks like we may have lost the feed there. So if Dr. Korsetz gets back in,
I'll
anyone else
jump in. I can't presume that I know what he was
Okay,
going to
then.
say, but
he's back. You want to repeat? You were frozen out there for a minute, Dr. Korsetz.
Oh, I'm sorry. I was just saying, for your safety, you don't want to be in a trial of an anti-amyloid medicine if you can't get an MRI scan, because it's absolutely necessary to see the side effects before they cause trouble. But there should be other studies that are being done through the ADRCs around the country. Those are Alzheimer's disease research centers, that not all of them require MRI, and those would be looking at different aspects of Alzheimer's. So PET scan would not, for instance, would be fine for somebody with a implant.
And it's great that CMS has just announced that they're going to allow more access to PET scans, and so this might be a good option. Next question is about brain donation, and this listener says that brain donation is discouraged by academic centers who insist that an individual is being treated or in a trial before they can donate their brain. Do any of you know anything about that? She said she was trying to make a brain donation, and then after 3 years, she gave up.
Well, I can only talk about our experience here. In most of the ADRCs, we do need to have some clinical information on the person so that we can correlate, whatever we see clinically, including cognitive testing, to what we measure in the brain. So, we don't tend to just take people who want to donate their brain. I'm sure other programs that do that. And so what I would encourage is that the person tries to get enrolled in one of the studies so that we can collect some clinical information. And then, we could work on getting the brain after that.
Okay, well, that makes a lot of sense.
Walter, you might talk about your.
Yeah, I would just urge you to Google Brain Donor Project, and there's a program to kind of democratize brain donation. I would say one thing that the greatest need for brains, actually the normal brains. So any study, you have to compare it to a normal brain. But there is, as Lisa said, to make it valuable, you need to know that somebody was normal, and what does that mean? What tests they have, who said they were normal. But those kind of things one could actually probably get from your physician or electronic health record. But check out Brain Donor Project.
Fantastic. So one other question that has come in is little bit out of what we've been talking to, but I think it's really important as we look at how do we translate science into actual practice. And this participant is asking, is it possible that hospital systems, why aren't primary care providers adapting computer tools like CanTab, which is the only FDA cleared tool, I guess, to detect dementia symptoms today? What do you think tests like these that have the highest level of sensitivity and specificity have been slow to be adopted by primary care hospital-based systems? So we really have, I think, seen with a lot of the new innovations that really focusing on specialty care and not so much on primary care, and may in fact be missing folks that they treat more regularly. So what do we do as a nation to make sure that primary care physicians who are treating patients with racial and ethnic and other types of social challenges, because we know that neurologists don't exist in every community. We know that PET scans don't even exist in every community.
I'll tie that in,
Yeah.
Stephanie, to our new ideas. So, after the original study had less than 10% racial and ethnic groups that have been minoritized, the new ideas study is 7,000 people, and that includes 2,000 people who would be Black and 2,000 people who identify as Hispanic or Latinx. And so, the study is being done in the clinical setting, and the primary group of people who are enrolling are dementia specialists.
Mm-hmm.
And so with all of our strategies to engage communities, to be thoughtful and tailor materials, we're still dependent on this people being able to get into dementia specialists. And guess what? What we already knew would happen is very challenging. Dementia specialists are not in these communities. They're not readily accessible, even for dementia specialists who are willing to take patients. They often have a long wait. So we really do need to spend more time developing that network of primary care physicians who feel confident enough to do these assessments. I think that's one of the challenges. Being married to a primary care physician, I hear it all the time. It's a very short visit. You want us to do a lot. And so what else are we adding into that assessment, that time slot that will allow them to feel confident that they're making the right diagnosis, that they have enough information to perhaps do the MRI and PET imaging or whatever else needs to be done to make a diagnosis. So I think, if we're talking about something like tapping, is that just going to be the route to get somebody referred to a dementia specialist, which will be challenging? Or is that part of, or are we talking about really a more comprehensive approach to preparing primary care physicians who want to be able to provide care to people with dementia? That's a different, I think, approach, and would love to see more focus on that.
Fantastic. Well, you have set us up well for some conclusory conversation amongst the three of you. Sorry, I included myself in that. But, as we started thinking about, sort of where are the weakest links in what we have now in the US. I know we all wish and hope and pray for more and better, but right now we've got 6.57 people living with Alzheimer's disease. That number is going to continue to grow. What is it that we can do right now? If you were the king or the queen, if we had such a thing in the US, and could prescribe for America what we need to do to create an equitable system to allow us to prevent, treat, diagnose, have good biomarkers, cure Alzheimer's disease, all of that, what would you do? What are one or two things that you would do to really bring more equity into this really critical space, given what we have right now? Let's hear the solution.
I'll go first. See, if I was queen of the world, I think I would tackle what we've been talking about as the accountability issue, right? I think somehow we have to force accountability into the system at the highest level, whether that's changing the laws, as we talked about, or changing the practices of the funding agencies. We have to do something different, because I think currently the thought is that what we're learning about Alzheimer's disease in a predominantly homogeneous white population applies to everyone, and then that implicitly or explicitly becomes the norm for science. And that's just not right. There's so much heterogeneity in society, and if we don't pay attention to that, in less than 30 years, when we're no longer, majority white, minoritized, it's going to be flipped. The health of the minoritized population is going to be the health of the nation. So we all have to care about this. So I would try to somehow tackle accountability.
Okay. Consuelo?
So in my mind, I am the queen. So just keep that.
I love it.
But if I could agree with the queen, Dr. Barnes, I mean, I would absolutely put my first focus on the accountability. That's the accountability of the researchers, of the funders, of the journal editors and publishers, of the manufacturers, industry. Everybody has to have some accountability for equity and good science. And that also leads to accountability in the health system and how we actually take the evidence and apply it. I mean, we have to take a step back and realize how much the evidence that we create and have created and use has been influenced by a specific group of people. And we've already talked about, that Walter pointed out, vascular disease more common in Black people. And so we see all of these less amyloid. And so why are we surprised then that the drugs don't work, or people are not eligible to actually take them? And so I think we have to accept some accountability whatever our role is in the system, and commit to doing things differently.
Okay. Dr. Koroshetz, bring us home.
Thanks for that question. Let me say that the problem that you talked about is not unique to Alzheimer's. It's all across our country, all across our diseases. So what I've been pushing at NIH is for NIH to set up a network that can do research in underserved communities, just so we can build the trust, we can build a sustainable system that, and we will engage people from the community to make sure it works. Because, as was said, you need people who look like the community for people to trust you now. And so I think that's what NIH really needs to do. We need a research network. We go into the community, we work with them about what questions they think are important and that they want to work with us on, and then we just do it and make sure it happens. And but the system now is not working. Yeah.
Well, thank you all. This has been a wonderful, uplifting, and realistic conversation. You've given us what we need to do, the roadmap for bringing equity and science together in our country for the good of all. And I will be working hard and diligently with each of you to make sure that this happens in our future. Thank you.
Thanks so much.
Thank you.
Thanks.